So I think as many of you know, as most of you know, surgery is really a hallmark of the treatment approach for ovarian cancer. There's not too many solid tumors where in the setting of there being extensive disease outside the organ of origin that we do extensive surgery, but ovarian cancer is one of them. This is a graph from data that Rob Bristow did when he was here at Johns Hopkins, and what he did is he went through the literature, and this really reflects about 8,000 patients, and he said, looking at the literature, what is the percent of maximum cytoreductive surgery on the x-axis, and then what is the survival on the y-axis. And what you can see is it's really pretty much a straight line correlation. The more disease that can be removed, the higher the percentage of the maximum cytoreductive surgery, the higher the survival. And it's data like this that has really led people and surgeons and those who care for ovarian cancer throughout the decades to consider surgical cytoreduction as an important component of the care in terms of trying of our initial treatment. We're going to talk a little bit about neoadjuvant chemotherapy, where instead of doing surgery right at the beginning, we give patients some chemotherapy and then do their surgery about halfway through their planned chemotherapy, and we'll talk about that. Systemic therapy for advanced stage disease has really been a standard of care. There's been a number of clinical trials over the years that have really, and this really now reflects about 25 or 30 years of data, that have moved us forward. And GOG 111 was published in the early 1990s, and this compared paclitaxel and cisplatin with the old standard of cyclophosphamide and cisplatin, and this showed that the combination of the platinum and the paclitaxel was better. GOG 158, which was published in the completed in the late 1990s and published in the early 2000s, looked at paclitaxel with carboplatin and compared it to paclitaxel and cisplatin, and found that the outcomes were not inferior with the carboplatin, and it was less toxic. And so, as most of you probably know, the paclitaxel carboplatin is sort of considered the standard at this point in time. There have subsequently been studies that have looked at a different taxane, a cousin of paclitaxel, called docetaxel or Taxotere, and essentially there's equivalent outcomes, which of those you use. They do have different toxicities. The docetaxel has less neuropathy, but it has more lowering of the blood counts. And so many will use the docetaxel instead of the paclitaxel. GOG 182 was a really large study that was a multinational study that had over 4,000 patients in it, and it looked at adding a third drug to the paclitaxel carboplatin backbone. And that showed that the drugs that were used were gemcitabine, topotecan, and pegylated liposomal doxorubicin, which is referred to as Doxil. And they found no benefit for the addition of the third chemotherapy drug. So we've really considered that dual chemotherapy drug, paclitaxel, carboplatin, has been our standard of care. And then there have been several studies using a weekly or a dose-dense approach with paclitaxel that certainly may benefit some populations. And that's kind of was considered a new approach at one point in time, but I think is still certainly used for some patients. We have looked at the use of chemotherapy specifically in the peritoneal cavity, which is referred to as intraperitoneal chemotherapy. And in GOG 172, we showed that the outcome was better for patients who got IP chemotherapy, but it was more toxic, and not even half the patients assigned to the IP arm could complete the therapy. In GOG 218, we looked at the addition of bevacizumab and showed that it delays progression but does not have a major impact on survival. And a European study, ICON 7, showed similar outcomes. And we're going to look at that in a little more detail as we go through some of the advances, particularly focusing on bevacizumab. GOG 252 looked at 2 IP regimens, one using carboplatin and one using cisplatin, and a third with IV. All those arms used bevacizumab, and that showed no differences in the outcome between arms. And that's been a little bit of a head-scratcher of a study for us. Nobody knows what is the standard arm, but this is, along with some of the other advances that have come along, have led people to move away from intraperitoneal chemotherapy. Neoadjuvant chemotherapy, which is chemotherapy used before surgery, does make surgery easier and less complicated, and we're going to talk a little bit about that. And HIPEC, which is heated intraperitoneal extracorporeal chemotherapy, with the surgery that's done after neoadjuvant chemotherapy, might benefit some populations. So we can talk a little bit about neoadjuvant, some of these specifically neoadjuvant. There have been two trials. There's the EORTC trial and the CHORUS trial, and both of these were randomized trials looking at primary debulking surgery, or PDS, and neoadjuvant chemotherapy with interval debulking surgery. And what you can see on the bottom lines is that the outcome in progression-free survival and overall survival wasn't statistically significant between these arms. However, when you look at, for example, the residual 1 centimeter, people who got, it was reported in the EORTC study that 81% of patients were able to get down to low-volume disease if they had chemotherapy first, compared to half that number if they had surgery at the beginning. And that if your goal is to have nothing that the surgeon's eye can see, which we call no gross residual, that was better in patients who got the neoadjuvant chemotherapy. It was 45%, compared to 18%. What we know with interval debulking surgery and neoadjuvant chemotherapy is that you'll have higher rates of optimal debulking. You'll also have lower surgical complications and lower rates of perioperative mortality, as well as shorter hospital stays. However, the cons are that the complete gross resection is usually less, and the median progression-free survival is shorter here than it is in patients in whom we're able to get everything out with the first primary debulking. And the median overall survival is around 30 months in all arms on these studies, but you can see that it's much greater by about 10 months in other trials where patients had primary debulking surgery. So we have this sort of yin and yang. The surgery will be much easier if you get chemo first, but your outcomes may be better if you get surgery first. And so this has led to doctors, surgeons in particular, having to have really good decision-making skills in terms of deciding, should I take this person to the operating room? Will I be able to get everything out? Is it going to be a 10-hour procedure with a 1-week stay in the ICU and lots of difficulty getting the patient in shape for chemo, or should I give them chemotherapy first? And so these are the things that we're struggling with neoadjuvant. There are guidelines from the ASCO and the Society of Gynecologic Oncology, and these are just that we've recognized that this is done, and we want there to be a rational, a reasonable approach to this. We do, and I think the thing that's potentially the most important on this chart is the first line, that patients should be evaluated either by a gynecologic oncology surgical specialist or a medical oncologist who has gynecologic oncology expertise to make this kind of decision.